It is truly a pleasure to be here and to see the incredible diversity. I mean, imagine this. We're a little country of Iceland with such diversity. My name is B.Ericksson. As you can tell from my accent, I'm clearly not an Icelander. By heritage, I am. I'm a Western Icelander. Actually, my great-grandfather was born in the Westman Islands, and he was one of those that migrated to Utah. So culturally, I'm a member of the Church of Jesus Christ of Latter-day Saints, commonly called Mormons. But today, I need to emphasize that the church does not take a position on circumcision. So I'm actually speaking now with my doctor hat on. I'm a board certified in 2 specialties, obstetrics and gynecology, and female pelvic medicine and reconstructive surgery, which is a long word for saying that I take care of all the awful things that happen to women. For example, I have been to Africa. I have taken care of women that have been genitally mutilated. I have seen the consequences of that awful, horrible thing. And I want to clearly emphasize that there is not, in fact, the World Health Organization states that we need to educate people that infant male circumcision is not in the same class, nor should be connected to female genital mutilation. The consequences of female genital mutilation invariably involves the removal of the clitoris, which is the sexual organ of the female, and that is clearly against any reasonable standards of human right and dignity. I wanted to just start out by reading a quote from a former member of the Utah Supreme Court, Dallin H. Oaks, on civility, because I think it's so important. A couple of weeks ago, I had the chance to be interviewed here in Iceland, and I was stunned when the next day there was all of this rancor and denigration against me as a human being, as a person. I don't know how they found things out and made this huge list of things attacking me as an individual. And so I thought, wow, why is there such animosity against individuals of different viewpoints? And he stated, on the subject of public discourse, we should all avoid contention. We should be examples of civility. We should love all people, be good listeners, and show concern for their sincere beliefs. Though we may disagree, we should not be disagreeable. Our stands and communications on controversial topics should not be contentious. We should be wise in explaining and pursuing our positions and in exercising our influence. In so doing, we may ask that others not be offended by our sincere beliefs. We should be persons of goodwill toward all, rejecting persecution of any kind, including persecution based on race, ethnicity, religious belief or unbelief, and differences in sexual orientation. So I was asked specifically, since a member of the World Health Organization could not be here, to review some of the experience that they have had in sub-Saharan Africa. And one of the interesting points from that is over the last 10 years, there's been a great body of literature, medical science literature, that has been generated from those initiatives, including what we call randomized controlled trials. When we think about the medical literature, there's a hierarchy of the quality of medical evidence. A randomized controlled trial are 2 groups of individuals where the application of an event occurs in one, and the second is a placebo. Those are the highest forms of medical evidence. The lowest form of medical evidence are clinical case studies, personal life experience that an individual has. Unfortunately, most of what we hear in the media and the press are someone's personal life experience, but that should be taken from a medical perspective to be the lowest form of evidence. Within the context, then, of the World Health Organization, in 2007, they reported, and I quote, "The research evidence that male circumcision is efficacious in reducing sexual transmission of HIV from women to men is compelling. The partial protective effect of male circumcision is remarkably consistent across the observational studies," those are mid-level scientific evidence, "and the 3 randomized controlled trials conducted in diverse settings. The 3 randomized controlled trials showed that male circumcision performed by well-trained medical professionals was safe and reduced the risk of acquiring HIV infection by approximately 60%. It is this body of literature that has helped cause organizations, for example, the CDC, the American Academy of Pediatricians, to relook at their prior position statements, which had been against circumcision, because there is some evidence that it may have a role and should be considered, at least as we approach circumcision, whether it is voluntary in adults or in certain cases where it may be appropriate to be considered within an infant. So their recommendations: male circumcision should now be recognized as an efficacious intervention for HIV prevention. In sub-Saharan Africa, 15 million individuals have been circumcised, and they estimate that the reduction in HIV rates will be over 500,000 individuals that will not be infected because of that medical intervention. Now, there's no question that places like Africa, where the prevalence rate ranges from 2 to 20%, is not Iceland, where the prevalence of HIV here is clearly less than 1%. In fact, I did a brief analysis, and it was 0.1%. But that does not mean, however, that the risks aren't here in this country. I don't speak Icelandic really well. Jag talar bara smalvesisynska. So unfortunately, I had to get my medical science from the Iceland Monitor, and I apologize that the statistics that I'm going to be briefly quoting are probably not necessarily that reliable. But they reported in 2015 that there were 332 tests positive for HIV in this country between 1983 and 2015. 38% of those were heterosexual sex. So this is not simply a male sex male issue or an intravenous drug issue. This is endemic in the ability for this to be transmitted through normal heterosexual sex. 2 years later, last year, the same authoritative journal, the Iceland Monitor, reported that in 2016, 27 individuals were diagnosed with HIV, which is double from the years previously. So if you take a look at this ever-expanding concern from a health perspective, the country should be aware that this is something that is very real. Unfortunately, we can't do a survey to determine who has HIV, otherwise we would have to invasively draw blood from every person. So the published rates of what is known does not reflect what may be endemic inside of the population. So this is a real issue, and it must be considered by Parliament and others when they make decisions about the possibility of circumcising prior to age 15. What are the risks of circumcision? Well, I think some of that's been brought on. I just want to touch point a couple of issues. The overall median frequency is 1.5%, but as has been discussed, and this is really important, it depends on who performs it and at what age it's being performed. For example, we know that there was a good study that looked at if the circumcision is done before 14 days of age, the incidence of complications is 1%. Between 15 days and 2 months, it was 5%. If circumcision was performed between 1 month and 9 months, it's 10%, and adolescence, it's 20%. That's because as the child gets older, you have to intervene with general anesthetics or spinals. You have to intervene with suturing techniques, which is not required in infants. I personally, as part of my training, have performed circumcisions. I've done hundreds of circumcisions in infants. Never had to use suturing material because of the smallness of the skin that is removed and the techniques that are devised. Urologists who do it in older children usually need to use some other additional interventions to mitigate against blood loss that can occur. What about in the non-sterile environment? If you are doing a circumcision in a non-sterile environment, you have an 80% chance of an infection. So clearly, doing it under sterile conditions. But does it always have to be a medical professional? Absolutely not. A very good study from Israel documented that circumcisions performed by both medically trained and non-medical personnel, but adequately trained, showed no difference in terms of complication rates on an extremely large series that was performed. What are some of the benefits? Now, again, the literature is all over the board here, and I could probably get into a debate with someone, and we could spend literally hours. But let me just throw out some statistics, as I only have a few minutes. We can have a more robust conversation another time. 60% reduction in HIV, 67% reduction in penile cancer, 35% reduction in HPV. Now, it was mentioned that you could do a vaccination, but the efficacy versus effectiveness, it is very effective if you give it, but the acceptance by the general population is diminished. So it's not a panacea unless it was mandatory that all children received it. Urinary tract infection is reduced by 1,000% in the first year of life and 400% in the course of the lifetime. The average reduction is significant, which also includes reduction in pyelonephritis, reduction in imaging, spinal taps, and other complications that attend that. Drug-resistant bacteria has been documented in repetitive individuals or children of non-circumcision where they had resistance to medications because of the amount of times that they received it. So the question is, would this law allocate and allow for a circumcision if a child received an infection? Well, how many would it take? In other words, how do you parse this? It becomes very, very complicated when you look at that. There is a 30% reduction in herpes, 60% reduction in fungal infections, 15 to 50% reduction in prostate cancer, and a 10% reduction in phimosis and other conditions. What about sexual impact? This is a common thing that's out there, and there's all kinds of anecdotal experience. Probably the best study that was done in Denmark. It was a systematic review of 38 studies, including 2 randomized controlled trials, looking at the outcome of sexual function in males before or after circumcision. The conclusion of this study, we don't have time to go through in detail, the hypothesis of inferior male sexual function following circumcision could not be supported by the findings of this systematic review. There's also a discussion frequently about first do no harm. I absolutely believe with first do no harm, but I think sometimes people will hijack that term and misdiscuss its actual meaning. First do no harm does not mean the first thing that I do to a patient shouldn't be harmful. It means that the balance of what I do, the risks and benefits, benefit if I'm going to do an invasive procedure. For example, a Harvard physician quoted this, and it's a good way to look at this. The idea that doctors should at the starting point not harm their patients is an appealing one. But if physicians took first do no harm literally, no one would ever have surgery, even if it was life-saving. We would stop ordering mammograms because they would lead to a biopsy of a non-cancerous growth. In fact, we might not even request blood tests, the pain, bruising, and bleeding required to draw blood, clearly avoidable harms. But doctors do recommend these things within the bounds of the ethical practice because the modern interpretation of first do no harm is closer to this. Doctors should help their patients as much as they can by recommending tests or treatments for which the potential benefit outweighs the risk of harms. Let's talk about immunizations briefly. I, last year, was invited to go to Zambia to do surgery there. I had been avoiding getting a yellow fever vaccine, and those of you that have had it know what I'm talking about. It is not a fun vaccine. But I was going to a high-risk place where that vaccine was now important. So I went through it, and I was in pain, and I was suffering because I was going from a low-risk environment to a high-risk environment. I want you to think about this clearly. In the families, culturally, where circumcision is an important part of their religious, the probability of a child at age 15 electing to have that procedure done is clearly going to be greater than 80%, right? So now you're taking this child from a low-risk situation, which is in Iceland, and that child is going to most likely and appropriately follow the religious tenets of their Muslim community or their Jewish faith and elect to have that done. So now you've moved that child to a very high-risk environment. One could argue that immunizing that child through a medical indicated circumcision early in life, medically indicated because it is a vaccination to avoid the possibility of severe complications when it's performed later. I mentioned that there is indeed over 20% chance of significant complications that can occur in a child or an adolescent that receives a circumcision. So if you're arguing that, well, you should ban all circumcision, that means that in those cultural communities where it is an important part of their culture, they're going to elect most likely to have that done. So now you are subjecting that child to a much higher risk of medical complications. Why not allow the parents, just as you would if they were making other decisions? For example, let's play sports. What if everyone from Iceland moved to a magical country where sports was outlawed? Because that country recognized that concussion head trauma, which occurs in thousands of youngsters from soccer, we call it in America, football here, that magical country decides, for the sake of children, we will not allow parents to let their children participate in sports. How would the Icelanders feel when they're going to the World Cup this summer? Cultural impact is a very, very important element to consider. In conclusion, I would like to talk just briefly about the law of unintended consequences. In the law of unintended consequences, we learn, and it was John Locke in 1691, that policy decision makers must consider What are the potential outcomes that can happen if they don't? Unfortunately, disasters can occur. And you can go all the way through the literature in many different countries where policy decision makers have made decisions because they're looking only at what their immediate desire is and not taking into consideration the long view. Ask yourself this question: if this is criminalized, as it is now written, what happens to the child when their parents are in jail? What happens to the child when they have to put on an airplane, take it to a country where they may not know the individuals and have the medical resources to have that procedure done? What about the child? What about the child who has that done and comes back into the country? And now the parents are afraid if their complication occurs, they're afraid to go to their healthcare provider because is the government now going to require that the healthcare provider must report that? So now the parents are worried that they're going to go to jail, and now the child is the one who suffers. Because the child is now going to have a delayed consequence, more increased risk of infection, more increased risk of concerns. What about that child? What about the individuals who have the circumcision outside? How are you going to have a monitoring system to determine who is circumcised? This is sort of tongue-in-cheek, but are we going to have a strip search program at the airport to examine every child 15 and under to come in so they can document the circumcision status of that child? And then every time a family that is of Icelandic origin goes on vacation and then comes back, are they going to be strip searched so that to determine whether or not circumcision has been done? What happens to the relationship between the child and his pediatrician or pediatric provider? These are the unintended consequences that must be in the conversation, as the government moves forward in what they do. And most importantly, and this is what I feel really strongly, we must be civil in how we do this. Because I guarantee you tomorrow, it's a good thing I don't speak Icelandic really well, because I would probably be hurt in my heart when I take a look at some of the comments that will show up on social media. Because I took a view that we should be looking carefully at the best interest of the child. And the best interest of the child includes a parent who loves and wants to shepherd that child through their life and allowing that family unit to do things, including the immunization of their child who at the time does not have a medical problem. But let immunization occur so when that child gets older, all of these consequences that we talked about, which don't show up at age 7 or 8 days of age, but may show up in the life of that child. Thank you.